Good day everyone, my name is Mubarak Yusuf and this is the question for today. A 30-year-old man presents with chest pain radiating to the left arm. ECG findings show ST segment elevation in lead 1 and AVL. Physical examination showed tall man with long extremity. Serum laboratory findings show elevated myoglobin and troponin I. His chart show IQ of 68 when he was 18 years old. He was accompanied by a family member who said he have a learning disability. The patient also said he has difficulty seeing, which started when he was 22 years old. Which of the following is the most likely cause of this finding, this patient finding? And these are the options: A, mutation in FBN1 gene; B, Golgi apparatus phosphotransferase defect; C, CGG repeat; D, defect in enzyme responsible for transsulfuration reaction; E, antibody against gastric parietal cell; and F, decrease in phenylalanine hydroxylase. So I believe everyone read this question and you should be able to figure out the answer, but we're going to walk through this step by step. The answer to this question is option D, defect in enzyme responsible for transsulfuration reaction. But let's walk through this. Option A says, before we even walk through it, what do you think the diagnosis is? We look at this patient. A patient presents with chest pain radiating to the left arm, right? ECG says ST segment elevation in lead 1 and AVL, right? And that's like lateral wall infraction, right? That's due to left circumflex artery occlusion. So this patient is obviously having myocardial infarction, right? And supported by what? It's supported by ECG ST segment elevation, and also the question is telling us that this patient have myoglobin, elevated myoglobin, and also elevated troponin I. So physical examination showed tall man, long extremities. When we see a tall man and long extremities, one thing that pumped to our mind is MARFAN syndrome. This patient looked like MARFAN, right? Then we further go on the chart. This patient have an IQ of 68. This is mentally retarded. And the family member supporting it by saying he had learning disability. That means this patient is mentally retarded. And now this patient also have visual problem, right? This patient have sight problem. So we can figure this out, that this patient is having MARFAN. This patient is having MARFAN like symptoms, right? Because from the look of things, is tall, long, thin extremities, right? That support MARFAN. But we can't say it's MARFAN because look, because we walk through it, why we can't say it's MARFAN? Because MARFAN do not have learning disability. They don't have mental retardation. And although MARFAN will also have lens dislocation causing sight problem, but they don't have mental retardation. And MARFAN can also present with chest pain, right? That is probably due to aortic dissection, but MARFAN do not have increased risk of atherosclerosis leading to myocardial infarction. So this patient is having MARFANOID habitus. So let's walk through it. Option A is telling us about MARFAN syndrome. So if option A is telling us about MARFAN syndrome, that is, as we already talked about it, MARFAN syndrome will not have mental retardation. This is not, this patient is having mental retardation. MARFAN syndrome will have long, thin extremity, hyperextensible skin, and all these other symptoms. But although the differentiating factor here you could see is number 1, mental retardation. Number 2, this patient is having myocardial infarction due to atherosclerosis and many other things, which we will try walk through the difference between MARFAN syndrome and MARFANOID habitus. Then B is Golgi apparatus phosphotransferase deficiency. This is likely talking about our eye cell disease. Our eye cell disease. When you look at our eye cell disease, the problem is that our Golgi apparatus fail to add -6-phosphate. Our Golgi apparatus our Golgi apparatus fail to add mannose 6-phosphate to the enzyme targeted to the lysosome. So that's why. And what do you have in this kind of condition? What you have in this kind of condition is that the patient will have, although they will have corneal clouding, right? And they can also have intellectual disability, but this is fatal. This is fatal in childhood. So, and we can see this patient is 30 years old. So this patient likely not to live up to this age if it is eye cell disease. And also they will tell you about lab finding of elevated lysosomal enzyme in the blood, but there's nothing mentioned in that here. CGG repeat. This is our CGG repeat is talking about our Fragile X. Our Fragile X syndrome. Some people consider Fragile X as X-linked recessive, some say X-linked dominant, but let's just know it's X-linked. And this is a trinucleotide repeat, right? And it's a problem with the FMR1 gene. And this patient tends to have large ears, and this is the second most common cause of mental retardation. So and when we look at our option E, right, our option E talking about antibody against parietal cell, this is our pernicious anemia, right? Pernicious anemia. And in pernicious anemia, you will tend to have vitamin B12 deficiency. You'll be vitamin B12 deficient, right? And if you're vitamin B12 deficient, you need vitamin B12 for key enzymes, right? For example, you need it for enzymes such as your homocysteine methyltransferase, right? You also need it for another key enzyme in your chain fatty acid metabolism, like methylmalonic CoA isomerase, right? So in a key distinguishing factor here is that, look, this patient, although this can give you homocysteine U here and an homocystinemia leading to also atherosclerosis, but this patient will not have MARFANOID habitus with long thin extremities because this is an acquired form. Acquired form due to vitamin is a bit different from congenital, and we walk through that. And phenylalanine hydroxylase, we know this is our nothing but our PKU, right? This is our PKU, and if someone is deficient in this enzyme, the way you treat them is by decreasing phenylalanine, and increasing tyrosine. Decreasing phenylalanine and increasing tyrosine. And now, so let's walk through. So now let's walk through the difference between our homocystinemia, homocystinemia due to enzyme deficiency, homocystinemia due to vitamin deficiency, and our MARFAN syndrome. Let's first walk through our MARFANOID due to let's first MARFANOID versus MARFAN. So MARFANOID due to enzyme deficiency. So this patient will have, in this one, this patient will have number one. This patient both will have long extremities, right? Both will have long extremities, right? And both will have lens dislocation. But in MARFANOID, the lens dislocation will be down and in. In MARFANOID, lens dislocation down and in, while in MARFAN it is up and out, right? In MARFAN it is up and out. In this, you will have thrombosis atherosclerosis. But in this, you won't have thrombosis, atherosclerosis, although you can have cystic medial necrosis of the blood vessel, which can lead to things like your aortic aneurysm, right? It can lead to aortic aneurysm, and so this is one of the key features. In this, there will be mental retardation, no mental retardation, no mental retardation. In your MARFANOID, due to enzyme deficiency, you will have increased serum homocysteine, and this you will no increase serum homocysteine. And this is basically the important factors here that you see that help you differentiate between both your MARFANOID due to enzyme deficiency in your homocysteine pathway and your MARFAN syndrome. So now let's now look between the difference between acquired homocysteine versus congenital, right? In acquired can be due to vitamin deficiency, right? And this is enzyme deficiency. And vitamin deficiency like your B12, like your B9, like your B6, right? And why here is due to either your sister thione synthase, or due to your homocysteine methyl transferase, right? And in the acquired form, both of them will both have increased risk of venous thrombosis and atherosclerosis. In acquired form, there will be no mental retardation, and this will have mental retardation. In acquired form, you won't have MARFANOID habitus. In congenital, you have MARFANOID habitus. So, and the congenital form can be either autosomal recessive, right? Most enzyme deficiency are autosomal recessive. While in our acquired form can be B12 can be either be due to strict vegan, or B9 can be due to maybe a pregnant woman, they need to take folate supplement, and our B6 can be due to someone taking isoniazid or chronic alcoholic. And basically, I think that's the important stuff we have for today. And thank you very much. I hope this really helped. Thank you very much. Thank you.